So I'm one of the major focuses of my research. I've got a lot of different lines of research, but I've always been interested and continue to be interested in the aging voice, both as a clinician and a researcher. And I'll tell you a little bit today about the genesis of it all that happened when I was a singing voice teacher, now several decades ago, which was my singing and teaching and singing were my first career. So we've got a lot to talk about, so let's go ahead and get right into it. The questions I'd like to be able to address today are just a general overview of what aging is, just so we kind of have a common language here. Then we'll talk briefly about how the voice changes with advanced age. We always talk about the aging voice. Really, we're aging from the time we are born, right? But when we talk about the aging voice, we usually are talking about the senescent or older side of aging. And then we'll talk briefly about some treatment options. And then I know we have some time for Q&A. And so if you'd like to know more about some of the research I do, I can talk about that, but I'll focus primarily today on the clinical aspects of aging. So let's get right to it and talk about what is aging. And actually, before we do that, let's say, why do we care about studying aging? Well, we collectively, as a human race on this planet, are getting older. If you look at these data, which are from the United Nations World Population Prospects report from last year, you can see estimates of the percentage of the population that are going to be 65 or older. That's on the top yellow line, or the bottom line shows you the increasing number of people, or the percentage of the population that will be over the age of 85. And so we collectively, as a human species, have been living longer and longer each year, and that means there will be more of us that will be older, that will have communication, voice, and swallowing problems that need to be treated by those who are attending today. And problems related to communication, relating to voice and upper airway, are really related, one, to health, but also heavily related to quality of life. Being able to be actively engaged in community, actively engaged in work. People are working into later years. People are retiring at later years, either because of wanting to be active or because of financial necessity. And being able to communicate with your voice is a critical part of that. And so a lot of aging research, even outside of the work that we do in our field, is focused on improving the quality of life as we get older, not just keeping us alive longer. And that goes back to my desire to help people who have older voices. When I was a singing voice teacher, I taught this woman whose name was Ruth. And Ruth came to me as a retired school teacher, and she had never taken voice lessons before, but she had always wanted to sing. So she was in her 70s, and I have to admit, embarrassingly, that at the time I was quite ageist. I didn't have high expectations for Ruth. And the first song that we worked on was Scarborough Fair, the folk song. And she, you can see with the phrase markings here, couldn't get through more than about a measure and a half with this. She had very decreased ability to sustain notes because of breath support. She had kind of a waver, a wobble in her voice. And I will come back to Ruth later because Ruth taught me a lot about what's possible with the aging voice. Okay, so let's turn now to that first question about what is aging. The definition that I like to use comes from a book by Robert Arking on the biology of aging, now almost 20 years old. And that definition is the CPID definition, which states that aging is a time-independent series of cumulative, progressive, intrinsic, and deleterious functional and structural changes that usually begin to manifest around reproductive maturity and eventually culminate in death. That's a little bit of a morbid definition, but that's how aging ends. And I think some of these aspects are fairly clear, right? We know that the aging is cumulative. We don't sort of age and then go backwards in age. It's a progressive thing and moves forward. But I want to talk about the intrinsic, deleterious, and time-independent aspects of this a little bit more. So the fact that age is time independent means that chronological age, right? When we say how old are you, and we tell in years how old we are, That's actually a very poor measure of biological age. And I'm sure that we all can think of people who are the same chronological age. I can recall my grandparents, my grandfathers, when they were about the same age. And one of them had difficulty, getting out of a chair on his own. He was almost immobile. And the other one, could still beat me in a game of tennis. So they were very different in terms of their physical capabilities. And if we were to measure their biological age, they would be quite different. So the takeaway is to not automatically assume or judge people based on their chronological age. Now we certainly see that in New York, where a lot of older adults stay quite active because they're walking everywhere and they're engaged in social activities, and they seem quite younger than their chronological age would suggest. The intrinsic aspect of the definition is also, I think, an important part, which is that aging is different than disease. Now, it's true that as we get older, we are more at risk for many diseases. Aging in and of itself is one of the primary risk factors for developing things like progressive neurological disorders like Parkinson's disease or dementia. So there is a relationship, or increased risk as we get older, but we shouldn't assume that someone's deficits or difficulties are due just to age. We say, oh, someone's just old, and so that's why their voice is very weak. We want to really assess them completely and look for any other diseases or disorders that might be present that might explain their vocal problems. So, and that also goes for people assuming that any problem that they're having as they get older is due to just aging. Right? There are lots of other things that could be going on that are quite treatable. So do a full evaluation and don't assume it's just age. So that's my first big takeaway, is not making any assumptions based on chronological age, because of the time independence and intrinsic nature of aging. All right. Let us now turn our attention to specific things that happen with the voice. So how does the voice change as we get older? Well, I think the obvious thing is that aging changes the sound of the voice. Again, we can think in our personal lives of people that we've been with throughout our lives, parents, grandparents, aunts, uncles, and we know that their voice changes as they get older. And I have an example here of an actress, and this first sample is from when she is 31 years old. This is an old recording from 1938, a movie actress. See if you recognize the actress. Here's her voice then.
Oh, yes, and I almost got arrested trying to help some strikers over in Jersey. Well, how was I to know the father was on the
Oops, sorry, make sure the
board of directors of the company? You see, Case, the trouble with me is that I never could decide whether I wanted to be Joan of Arc, Florence Nightingale, or John L. Lewis.
So that's Katharine Hepburn, the movie star from the 30s, 40s, and 50s. And here she is now in an interview when she's 81 years old. So this is 50 years later. And the recording environment is different, and she's talking about something emotional. So there's other things that probably are affecting her vocal quality other than age. But there's some things that are quite different. Just listen to this now.
I kissed him goodbye, walked over to the door, and Spencer walked over and patted his shoulder and said, we're on our way. And Bogey reached up with his hand, patted Spencer's hand, looked at him, and said, goodbye, Spence.
We can hear the frequency, fundamental frequency is lower. There's some raspiness, roughness, and breathiness to the vocal quality. She did have a vocal tremor as well, which I wouldn't say is due to age, but like I mentioned earlier, many diseases are more common as we get older, and so that essential tremor is likely she got as she was older, and so it's a very different quality to the voice, and that's what we notice. And in fact, there are some interesting studies that show that just by listening to the sound of someone's voice, we're pretty good at judging how old they are. In fact, just as good as if we were to look at a picture. So our visual and our auditory perception of a person matches in terms of judging someone's age. However, as I was talking about intrinsic nature of aging, If someone has disuse or disease and overall physical condition is poor, that can change our perception, again, both visually as well as auditorily. So we're pretty good at it, but be cautioned that other things can affect our perception other than the actual chronological age. All right, so what's underlying these auditory perceptual changes? Well, because the entire body is our instrument and the entire body changes as we get older, there are age-related changes throughout the entire body that can affect the voice. When we think about the mechanics of voice production, we think about them, I at least think about them like an acoustic instrument, in that there is an energy source. In case of the voice, that's the breath, the aerodynamic forces produced by the muscles of respiration. There's a source of sound, which is the vibrating vocal folds here in the larynx. And then we have that sound resonating in our vocal tract, and that resonance gives us much of the quality of the sound. And all of these three components, subsystems, are controlled obviously up here in the brain. So I'm not going to talk really about that a lot today, or at all today, except for right now. But there certainly are neurological changes that change the control of these three subsystems and the coordination of the subsystem. So it may not be something kind of mechanical. There could be control systems that are aging, right? Cognition slows down, the speed of muscle contraction slows down because of changes in the innervation of the muscles. So there are central and peripheral nervous system changes as well that affect the way the systems are coordinated. So let's take a look at each of these three mechanical subsystems, starting at the top here with the vocal tract. Atrophy of the tongue muscles and the surrounding pharyngeal muscles is a key part of aging. I'll talk a little bit more about that in a few minutes. And that happens really throughout the body. And that atrophy of the muscles, which is known as sarcopenia when it's related to aging, changes not only the size of the muscles by decreasing the size, but also decreases strength and decreases the speed of the way the muscles contract. And so that can affect articulation. If we're talking about elite performers like vocalists, that can affect some of the fine adjustments that they need to make to get the quality of sounds that they try to produce. We also have a lowering of the larynx within the neck. And so this resonance tube, the vocal tract, as we change the length of that tube, we change the resonance and the quality of the sound. And so if I were to kind of yawn and lower my larynx here, you can hear a deeper sound. Whereas if I raise my larynx, now it's a more tinnier sound because I'm changing the length of my vocal tract. And so that happens in aging, where that drops along with the fundamental frequency. So it can provide a little bit richer, deeper sound. That may be one of the good things about aging. Most of what I talk about with aging are negative effects, but there are a few potential positive effects as well. I mentioned on this slide decreased sensitivity of the upper airway, not so much as it relates to voice, but definitely as it relates to swallowing. And we see that with decreased sensitivity, people may have an increased chance of premature spillage or aspiration of material because they're not triggering the swallow at appropriate times. So that's something to be aware of, because voice and swallowing are so closely related in terms of the mechanisms and the pathways. Moving now down to the energy source, the respiration system, the primary change that we have within the respiration system that influences voice production are calcification of the costal cartilages, so a stiffening of those cartilages, and a weakening of the respiratory muscles, the atrophy that I mentioned earlier. And combined, that leads to a decreased respiratory capacity, meaning we have less power, less air available for us to produce our voice. So if we think about some of the typical complaints of the aging population with their voice in terms of difficulty projecting, difficulty sustaining their voice over longer periods of time, all that can be traced back to this decreased respiratory capacity. Now let's turn to everybody's favorite organ, mine certainly, the larynx. We're very laryngocentric, I like to say, in the voice world, but it's good to remember the whole body is what's involved in producing the voice, not just the larynx, but the larynx is important. And here we have two images. One is an endoscopic image, something we would see in the clinic here on the left. And the one on the right is an excised larynx from a cadaver, so post-mortem larynx. And some of the changes we see on the right may be due to it being post-mortem observation, but I've drawn some lines in on the right side where we would expect sort of a normal vocal fold to be along this edge. And this bowing appearance, this kind of concave appearance of both vocal folds, is the typical appearance of the older larynx that's undergone some sarcopenia. We call this a presbylaryngis because it's the aging of the larynx, and that's primarily due to underlying vocal fold atrophy. And what that does clinically then, when we look at the larynx, as we see on the left in this slow motion video, is when the individual tries to phonate, there's a persistent gap in the center. So the vocal folds just aren't coming together all the way because of what we assume is that bilateral atrophy. Now, we can't see the atrophy per se endoscopically. We see the likely results, meaning the bowing of the vocal folds because of the loss of that tissue. But not only does the tissue change, the overall framework can change as well. We have a little bit of degeneration of the joints, particularly the cricoarytenoid joint, some ossifications of the cartilages. And some people say that some of that ossification can be beneficial because it might provide a little more stability for vocal production to an extent. I think that in singers in particular, we notice a maturity of the voice into the 30s that really kind of stabilizes, and we hypothesize, although we don't have data to support this, that ossification of the cartilages is part of what leads to some of the stability of the voice in midlife. But within the vocal fold itself, I talked about the atrophy. That atrophy actually can change the entire layer structure of the vocal fold. Right? There's the underlying thyroidnoid muscle in this classic picture by Hirano. This is an actual human vocal fold. We have then the different layers of the lamina propria here, which provide a lot of the biomechanical properties that help the vocal folds vibrate, and then the outer epithelium. So going from out to in, the aging epithelium, we see a change in thickness in the epithelium, although there's a little bit of conflicting evidence. We see that some people report there's a thickening, some people report that there's a thinning of the epithelium, and we probably just don't have enough samples from humans to really know this. Because we're such a niche field, studies of actual human samples are relatively rare in the grand scheme of things. So a little bit of conflicting evidence, but we can conclude that there is some change and likely some change in the stiffness of that outer layer that impacts the biomechanical properties and how it vibrates. Going to the next layers down, the lamina propria, we have those three layers that consist of some of the important molecules that give it those biomechanical properties, in particular the elastin, which gives it its stretchiness and springiness to return as it's vibrating. The collagen that gives it some stiffness that allows us to change and have a wide range of fundamental frequencies to really generate these high degree of stress within this small tissue. And we lose some of the elasticity of that elastin, and we also lose some of the organization of the collagen, which again can then change the way the vocal fold vibrates. We do see a little bit of a difference between male and female larynges as we get older. I mentioned the change in fundamental frequency going lower. That's more typical within the female larynx, whereas it's more typical for male fundamental frequencies to rise over time. And that has to do with how these different layers are changing between the male and female aging larynx. Back to the TA, a little more detail here. We see that there is a reduction in the size and the mass. That's the atrophy or sarcopenia. But other aspects are a conversion to a slower muscle fiber type. And so within our skeletal muscles, we have two primary types of fibers. The slow muscles are the ones that we use for endurance type activities, or like our postural muscles, where we need to stay upright and keep our torso in position for long periods of time. So low level, slow contractions. Whereas our fast muscle types are the ones we use for more ballistic, powerful, quick movements. And the fast fiber types are more predominant typically within the thyroid muscle, but we start to see a shift in those muscle fiber types to slower. One hypothesis for that is that that's important to help us continue to have the function we need for breathing. Right? The larynx has this shared pathway. I mentioned swallowing and voice are together, but breathing is probably, arguably, the most important function we have within the larynx so we can stay alive. And so regulation of the opening and closing and making sure we can stay open of the vocal folds during breathing, which is a slower activity than voicing, may be why our body has adapted to convert to those slower fiber types. And overall, though, because of that conversion and the shift in the way our muscles use energy, which is that reference to the metabolism there, we have an overall decreased speed, force, and endurance of our laryngeal muscles. Now, a lot of what we know about aging muscles comes from the limb musculature, and we can learn a lot because the limb muscles are skeletal muscles like the laryngeal muscles. But a lot of my work has been on looking at how they're different. This is a review paper that I've based a lot of my work on by in Joe Stempel's lab in Kentucky. And it's a really nice overview of how skeletal muscles, meaning limb muscles, are different than the thyroid muscle. So even though we can learn a lot, there are some caveats, and we do need to directly look at the laryngeal muscles, which is, again, part of what I've done, primarily using a rat model to look at changes in age and also with vocal exercise in the TA. So takeaway number 3 here is that aging affects all of the systems involved in voice production. We are laryngocentric. We do focus here on the larynx, but as you're treating someone, and I was very pleased when I met everyone this morning that it was not just physicians, but we have SLPs here as well. That's really the gold standard of assessing and treating individuals across the lifespan, is to look at the medical aspect, to look at the anatomy, but also to think about the function, which includes the coordination of all these systems. So it's great that you have a multidisciplinary team here. All right, let's see. Let's chat a little bit more about sarcopenia. This is a series of images I like to show when I talk about aging and musculature. This is Arnold Schwarzenegger in his youth, and then as he's older and he was deconditioned. And I used to show that second picture there in the middle as a demonstration of aging effects. But then, I realized that was a little unfair because Governor Schwarzenegger has kept up his exercises, and he's actually pretty buff I think he's in his mid 70s now, or 70, somewhere around there. At any rate, he's a nice example of how aging is something that we don't have to give into, right? We don't just say, well, we're old, my muscles atrophy, that's just the way it is. That exercise can be used to counteract the effects of the aging process on the voice. And so if we look at this schematic here, we see that we start to increase muscle mass early in life. And then as we get older, the goal is to sort of maintain our what we've achieved in younger years and to avoid decreasing down to what's called the disability threshold. And as we get older, 65 or older or so, if we have a loss of strength and endurance of our muscles, that could lead to an incident that might then lead to more permanent disability. But we have a big range, right? It's not that we are automatically going to go into the disability. We can, through exercise and use of our muscles, maintain full function. We don't need to necessarily go down into the disability threshold. And that's work that comes from the limb muscles. And so the question is, can we do this within the larynx? Can we exercise the aging voice as well? And to look at that, let's look at sort of what exercise is. And when I talk about exercise, we're talking about some activity that we're doing to change our muscles, some plasticity of our muscles. And the way that the muscles will adapt depends on the kind of activity, the kind of stimuli that we're presenting. And so on the slide here, you can see some different types of runners. The two runners in the middle are sprinters, and they've trained themselves for ballistic, high force types of activities, running for as fast as they can for very short distances. Whereas the runners on the outside are marathon runners. They've trained themselves for slower running over longer distances. And you can just, by looking at them, see very different body compositions. And that's due to the different types of training that they've done. And so we have this continuum of training. It's not really a division. It's not really one or the other, but it's a continuum of activities where endurance training, like the marathon runner, is relatively low levels of muscle activity, but over very long periods of time, versus resistance training, where we're trying to work our muscles as hard as we can. So if we think of things like your maximum force that you can going 80% max is one of the sort of thresholds to say I'm trying to get to 80% of my maximum lifting, and that's going to build the muscles and increase the strength. And so here's that a little bit more definition of the resistance training, and we can apply it to the voice and say, what does that really mean for the voice? What kind of voice use might be kind of that resistance ballistic type training? That might be something like using a louder voice. You know, when we're louder, that the muscles in the larynx are more contracted to provide more adducted, to provide more resistance to the aerodynamic forces. We're also using more of our respiratory muscles to engage and provide higher subglottal pressures. And so a louder sound is potentially one example of a resistance training. Now, the challenge, of course, in the voice is that we can't directly measure the amount of muscle contraction. Sure, we could, put some EMG needles in there, but we're not going to do that on a regular basis. And so we have to use sort of just some theories about what kind of voice might be more of a resistance activity if we're trying to build strength. Now, I will say in the research I've done and the research that I've read, I haven't seen any evidence that we can actually build the strength or the size of the laryngeal muscles. That doesn't mean that those exercises aren't beneficial functionally, but when we say strengthening the muscles of the voice, I'm still not entirely sure we're actually strengthening the tiny TA muscles. And that's because when we think about the maximum contraction, if we swallow or we do a Valsalva movement, we like that, we squeeze very tightly, we're contracting our intrinsic laryngeal muscles much more tightly than even a loud vocalization. Right? If we were to maximally contract our intrinsic laryngeal muscles during voicing, well, we couldn't do it during voicing because they would be completely tightly closed and that we wouldn't be able to pass air through. So I don't think that even loud voicing gets anywhere close to the amount of contraction we need to build the size of the muscle, which means that if we have severe atrophy, that a behavioral approach may not be sufficient by itself to get the gains we're looking for functionally. I'll go to the treatment slides in just a moment. Evidence we do have that that exercise is helpful for the voice comes from singing. And we see that there are studies from professional singers looking at people observing voices, listening to voices, and singers are judged as younger in terms of the perception of their voice. And they also outmatch them not only in perceptual, but also in acoustic measures. They are measured as having a more younger voice than age-matched non-singers. So that's one piece of evidence that by using your voice in what I would say an athletic way, we oftentimes call our singers vocal athletes, that that athletic use of the voice can lead to keeping the voice younger. And it's probably not just what's going on with the vocal folds, but also has to do with that coordination with the respiratory and the resonance systems as well. And I promised you I'd come back to Ruth. And so Ruth is another of my own anecdotal evidence that singing can be helpful for the aging voice, because she practiced harder than all of the college students that I was teaching. She came to all of her lessons, and she was such an incredible student. And she proved me wrong. I had low expectations, and she blew them out of the water. And I learned a lot about what regular practice, regular training can do to improve the voice. And you can see that she reached her goal here of singing this first phrase in one breath. She was able to improve her breath, improve the stability of the pitch, and she really was the impetus for me being interested in continuing to then study the aging voice. Let's talk now briefly about, we've talked about sort of typical changes, and I've mentioned a few things related to pathology, but let's be more explicit now about what we mean by problems related to aging. And so presbyphonia is the term we use for an age-related voice problem. Now that's different than presbylaryngis, and I'll talk about that in a moment. We see that there are some studies showing us that there's a pretty large prevalence of voice problems in older adults. Now, unfortunately, we also see in these surveys that older adults tend not to seek treatment for their voice problems. And I think that's because of what I was saying earlier about people assuming that loss of function is normal within aging. And so I'm just old, there's nothing that can be done. And I can't tell you how many people I've met in the clinic who've come in and they said, "Oh, I'm so glad that I'm here. I had no idea there were voice doctors. I didn't know people could help me with this until a friend told me, or my pulmonologist referred me, and I think we've got a big public relations problem within the voice world. We need to let people know that there is help to be had for all voice complaints, and especially as we get older. So, presbylaryngis, which I mentioned earlier when we were looking at that endoscopic image, is different than presbyphonia. Presbylaryngis is the appearance of that bowed vocal fold, and not everyone who has signs of presbylaryngis has a voice problem. Remember, the voice is more than the larynx. And there was a really great study. I should update this reference. I first saw it at a conference, but it went on to be published then. But this paper showed that people coming into the clinic with a voice complaint who were older adults over 75 had presbylaryngis, age-related changes. But then they looked at their partner, the person coming in with them, who did not have a voice complaint. And they showed that just as many of the partners that were coming in had observable changes, age-related changes in the larynx, despite not having a voice complaint, meaning that the quality and function of their voice was just fine for them. They didn't have any problems. So important to distinguish the difference between age-related changes of the larynx, presbylaryngis, versus presbyphonia, age-related voice problem. One thing I want to point out that's come out in the past couple of years is the Aging Voice Index. And this is a new quality of life tool, relatively new, that focuses specifically on voice complaints of the older adult. And so if you're using quality of life forums like the Voice Handicap Index or the VRQOL or anything else, I would encourage you, if you are increasing your population in the older adults, to consider using this because it is specific to the aging voice. It doesn't ask questions about, say, employment, and it's been validated in older adults. So I just wanted to spread the word about this particular tool. All right, so we know a little bit about what's happening with the voice and the problems. Importantly now, what do we do about it? How do we help folks that come in with an age-related voice problem? As I was saying earlier, it's a multidisciplinary approach. And so here's an image of some members of my crew here, the team that I work with. We have two laryngologists in the middle there, Dr. Milan Amin, and on the end, Dr. Paul Kwok. And we're being joined this fall, our current laryngology fellow will be joining us as a fellowship-trained laryngologist by us, as a member of our team as well, Dr. Ellie Morse. These are three of our speech-language pathologists. We have a couple more now since this picture was taken. And we work together in the clinic to side-by-side diagnose individuals with voice problems, because not only the diagnosis, but the treatment really must be multidisciplinary. So as ENTs, what can you all do? Well, the primary thing as an ENT, as a laryngologist, is you focus on the larynx. That's in the name of your profession. And the primary intervention for older adults is to help close the gap. So we've talked about this bowing shape of the vocal folds because of the atrophy. And the primary tools that laryngologists have in their toolbox are to either medialize the vocal folds through an injection, which can be done in office. We do that quite frequently in our office. So I oftentimes will hold the scope while one of my physician colleagues does the injection. And all the injectables that we currently have available, which would be injected laterally, this is an important point, that when a medialization injection is done, it really should be done away from the vibrating edge. Because if we're injecting something here on the edge where the vocal fold should be vibrating, any material that we inject is going to affect the biomechanical properties. It's going to be stiffer than the what's existing in the lamina propria. And so if we're trying to bulk up and move the vocal fold to the middle, we want that injectable to be off laterally to the side and not anywhere close to that vibrating edge. All of the current injectables that I'm aware of anyway are temporary. They will be reabsorbed by the body. Depending on the injectable and the person, it can last 3 to 6, sometimes a little bit longer, months, that is, sorry, 3 to 6 months. And oftentimes it's used by my colleagues, my laryngology colleagues, as a test run to see if a more permanent procedure, like we see down here, which is the thyroplasty, might be a helpful procedure. So the thyroplasty is done in the OR. It's done while the patient is awake. And the reason that that is so that as this block is being inserted through the hole in the thyroid cartilage, sometimes flexible Gore-Tex ribbon is used as well. There are a couple different types of materials, but as that injectable is being put, or sorry, as the implant is being put into the vocal fold, the patient can actually phonate and the physician can determine how close the vocal folds should be. And this is a relatively permanent procedure. There's some data showing that revisions are needed in some percentage, but it's a much longer lasting and relatively permanent compared to the injection. But as I said, this is a multidisciplinary effort, and there is some good evidence from the literature that behavioral voice training provided by speech pathologists are effective as well to improve the quality, the volume of the voice. And what's interesting is that this review article, now about 10 years old, shows that there is evidence from 3 approaches in particular: the vocal function exercises, the phonation resistance training exercise protocol, and an adapted Lee-Silverman voice training protocol, which was originally developed for individuals with Parkinson's disease. And what's interesting about these 3 approaches is that they all have some sort of maximum function vocal task. So recall I was talking earlier about strength training and about trying to maximally contract our muscles. So even though we're not maximally contracting our muscles, we are sort of doing maximum vocal function. And the type of maximum vocal function may be endurance. So with vocal function exercises, for example, you hold out a sound for as long as possible, so increasing the maximum phonation time. With phonation resistance training and the Lee-Silverman voice treatment, those both have loud tasks where we're trying to use our voice as loud as comfortably possible. We do have to balance loudness with effort. We don't want people to be straining or feeling like they're screaming. So loud in a coordinated way, not just with an effortful laryngeal way. And then all 3 of these also have maximum frequency tasks as well, where we're trying to raise the frequency to higher than what is typical. So they're all kind of incorporating some concepts of strength training, and those have been shown to improve the voice. Now, again, if there's a large glottal gap there, the vocal folds just aren't coming together, then any amount of behavioral training is likely not going to improve that. But oftentimes in conjunction of some sort of medialization with behavioral training really can be an effective approach. So absolutely. So the Lee-Silverman voice treatment is a protocol that was developed for individuals with Parkinson's disease. It's a very intense treatment. So it requires individuals to come in daily to work with a therapist. Now, with the advent and acceptance of teletherapy, that has made this kind of interaction much easier. However, there oftentimes are insurance challenges with seeing people this frequency, at least in the States. But it focuses on maximum phonation time, so increasing the length that someone can use their voice, increasing pitch range, so doing pitch glides up high, and then doing high effortful voice production in functional speech. So you'll create phrases that someone might use on a regular basis. So if someone interacts with their spouse regularly and asks them to pass the milk, you'd say, "Please pass the milk," and you would train them to use that at a louder intensity. And then there's daily home practice as well. And to actually do LSVT properly, you do need to be trained in that. And that's part of the reason that my colleague Aaron Ziegler and colleagues developed Forte. And so that's a fun homonym for Forte being the Italian word Forte for being loud. This is a clever homonym, so the phonation resistance training exercise. And it uses the same principles and exercises that are from LSVT, but they're done with one session a week with the therapist. So instead of that intensive one-on-one with what's required for LSVT, this allows the home practice twice daily with once a week in person. And there are training sessions in this that I know that Dr. Ziegler and Dr. Edie Hapner provide. So you could take a look out for those. But the overall idea of both LSVT and Forte are to help people increase their effort in a positive way. I oftentimes am a little hesitant, like I am now, to talk about increasing effort because we don't want people to be straining and feel like it's hurting. The adage in no pain, no gain, it does not apply to the voice. We don't ever want our patients to feel like voice production is painful. It might be a little more intense, a little more energy. Edie Hapner uses the word exuberant to talk about sort of just larger than what is normal. So it may be a little more effortful cognitively and a little bit more kind of overall physically. But I would just caution that we're not having people strain and try to really work hard from the larynx. So it has to do with engaging the respiratory system, and feedback can be helpful too. So nowadays on smartphones, you can get dB apps, intensity apps that measure that either specifically for the voice or just general, sound level measure. And you can use that as a way to give feedback so that people know how loud they're being. Because sometimes hearing loss is very common in older adults as well. So it may be that someone is talking quietly because of the hearing loss, or conversely, I've seen where people are talking more loudly because they can't hear themselves as well because of hearing loss. And that's also has to do with the communication partner. So if someone comes in and say the husband is talking about the voice problem and the wife says, "I can never hear him," you say, well, maybe ask the wife, "Have you had your hearing checked?" Because there's that goes both ways, right? To be heard, we need to have good hearing, and not to assume that's involved, but that's something to be aware of. Does the communication partner have a hard of hearing? In my work, in the past, well, now 15 years, I guess, I've been using the ultrasonic vocalizations of rats as a model to look at the underlying neuromuscular system of the larynx. And let me explain what I mean, why I've been doing that. So rats use ultrasonic vocalizations to communicate with each other. When we hear rats vocalize, they're audible vocalizations. They sound like squeaks, and they produce those squeaks when they're scared or when they're in pain, which is generally the state they're in when they encounter a human. But when they're communicating with each other, they vocalize up around 50 kilohertz. So our range of hearing goes up to about 20 kilohertz, whereas they vocalize quite a bit above that. And they use those vocalizations to communicate their emotional state. So there's different frequency ranges that are used if they're warning each other of predators versus if they're expressing interest in social situations like in mating or rough and tumble play that happens with juvenile rats. And so here are a couple of sample vocalizations. When we look at the vocalizations, we can use spectrograms just like we do with human vocalizations. And we'll listen to 3 of them here. The first one is a relatively flat. There's no variation in the frequency. And I should mention these are slowed down. I just told you they're above our range of hearing, but if we slow them down, then we can make them a little lower frequency. This middle one is quite complex. It's a trill frequency modulated call. And then the last one here, the harmonic, where it starts around 50 kilohertz and then abruptly breaks into this fundamental frequency with a high harmonic. And these are all created within the larynx using the same neuromuscular mechanisms that we use. So the thyroidnoid muscle, the arytenoid cartilages are similar, although the proportion is different. So they tend to have, whereas in humans, it's about the anterior 2/3 is membranous in the larynx of the vocal fold, and the posterior third is the arytenoid cartilage. It's the opposite in rats. So that is one difference. But an important similarity is that both rats and humans use the TA and the CT to modulate the frequency of their vocalizations. And so by looking at the frequency modulations and targeting increasing frequency modulations in our training is how we are then looking at increased use of the laryngeal muscles in this paradigm. And so we have shown that we can increase the number of vocalizations that a rat produces over time through this paradigm. And you may be wondering, how do we do that? Well, rats, like all mammals, are motivated by sex and food. So we pair male and female rats together, and then we separate them, which causes them to vocalize. And then we give them a little reward, either some like sugar water or a little treat, and that reinforces the vocalization. And then over time, we can increase how much they're vocalizing, and eventually we can remove that stimulus of the male-female pairing, and they just know when they're in their little chamber, they're going to get their reward if they vocalize. And so we can get them to vocalize hundreds of times in a very short 5 to 10 minute session through this paradigm. And if you're interested in learning more about it, we do have a Journal of Visualized Experiment protocol that's now, we did when I was back at University of Wisconsin-Madison. And so you can see the video of how we train the rats and reinforce it in this article here. And more recently, I've worked in my lab here at NYU to automate the procedure. And so now we have a system where the detection and reward of the vocalizations is all automated so that we're not having to manually give the reward, because that led to some variability in how the rewards were produced. And so what we found with this model over the past decade or so is that we are able to not only increase how much the rats are vocalizing, but we also are influencing the acoustics and the neuromuscular junctions of the animals. And we looked at the neuromuscular junctions because if there's going to be any change within the muscle itself, that is usually preceded by a change within that connection between the peripheral nerve and the muscle. That's the NMJ, or the neuromuscular junction. And we've seen that in limb musculature with training as well, where the structure of that NMJ changes as we increase the use of the muscle. So in terms of the acoustics, we showed that in our trained group, that at baseline, rather before we trained, that our old animals had a decrease in the overall amplitude or intensity of their vocalizations compared to the young rats. And after we trained them, we didn't see any difference really in the young animals in the intensity, but we did see an average increase in the intensity in the old animals that were trained. And that was a really nice mirroring of what we see with our humans. And that was something we weren't actually targeting with the training. We were only targeting on increasing how much they vocalized. So it was an interesting kind of side finding that just increasing the amount of vocalization also increased the intensity. And we might be able to apply that to humans as well, that an increase in the amount of voice use as we get older could just be helpful in general in maintaining our voice. Oftentimes when older adults are retired, or maybe their social situations, people start to pass away, or they're not as engaged, they just aren't talking as much. They aren't using their voice as much. So simply increasing their voice use throughout the day can be a helpful intervention. Oftentimes I'll ask people if they read the newspaper or they read a book and on a regular basis. And if they do, I just say, well, just read that out loud. Just use your voice, even if there's no one around, to keep yourself active. In terms of the underlying physiology, then, we saw that within the neuromuscular junction, here's two microscopy images of neuromuscular junctions. And these are both from old rats, from aged rats. And what we see is typical here on the right, where the NMJ begins to sort of break apart. And what that functionally results in is a decrease in the efficiency of the signal that goes to the muscle to tell it to contract, which can lead to weakness or decreased speed of contraction. And what we've found in this study, and also in two follow-up studies, is that our vocal training paradigm with the rats decreases this dispersion. So we see on the left here a more tightly packed motor end plate within that neuromuscular junction. And that's a result of the training. And again, we've shown this actually. This is from the first study we did now quite a while, over 10 years ago. But in a series of subsequent studies, we looked at the same outcome and found the same thing. So I feel pretty good in this finding. It's been replicated. And what it tells me is that that is more similar to an endurance type training, because we haven't found any change in muscle hypertrophy, meaning the size or increase in size of the muscle. So this is one of the follow-up studies. We see that in the short-term training in 4 weeks, there was no change in acoustics or NMJ, but this long-term training here did result in increase in acoustics, meaning the intensity, like I showed you, as well as the peripheral neural adaptations, the more compact NMJs, but neither of these paradigms resulted in any sort of muscle hypertrophy, increase in muscle size. That's shown here by that arrow. Now, it's very possible that our paradigm just isn't rigorous enough to induce muscle hypertrophy, but the only evidence I've seen from the literature that shows that older laryngeal muscles can hypertrophy has come from a stimulation study where they applied electrical stimulation to the nerve, and that then made the muscle contract at maximal amounts. Remember, I said earlier that through our vocalization, we can't really maximally contract our muscles, but with external stimulation, nerve stimulation, we can get the muscle to contract fully. And so in that paradigm, they did see muscle hypertrophy. So it's likely possible that the laryngeal muscles can increase in size and strength, but it would take a much greater stimulation than we're able to provide behaviorally. All right. Any questions about, I just gave you kind of a quick overview of some of the basic science stuff. Any questions about the way that we're investigating this from a basic science standpoint with the rats, about how we're doing the training or the things that we found? I'm happy to answer, or just sort of, sometimes people are like, why rats? Why are you using rats? And the basic answer to that is that we're able to do studies like this where we can actually take the muscles out and we can look at them directly and figure out what's happening and look at the mechanisms of change. And we can't do that with humans, right? No one's going to sign up to have their TA muscle removed and looked at. So basic science studies like this help us understand the underlying mechanisms that are happening biologically with our interventions. And actually right now we're doing a study where we're looking at injury of the outer vocal fold layer and how that affects the muscle. And we are looking at contractile properties of the muscle itself. So we take this little rat larynx, which is about that big, and I have a very skilled surgeon in my lab who takes half of that larynx and connects the thyroid cartilage and the arytenoid cartilages to some sutures. and then we put it in a solution and give it a little jolt of electricity, which makes it contract. This is after it's been excised. And we can then measure because there's a force transducer connected to the suture, we can measure the force and speed of the contractions of the muscles. So we can actually get these measures, which we could, as I said earlier, not do in humans or even do in vivo in an animal model. So I'm very excited about that work.
Aaron, there is one question.
And look, I see the question about communication codes. That's good. Like, what do they mean? We know from the psychology literature that, because psychology also looks at these, we know basically what I showed you earlier, which is that there are happy and sad or positive and negative affects that are expressed through these different vocalizations. But we haven't gotten any deeper than that. Like, we don't know the language of the rats. We can't determine the words that they're saying. But I'm hoping that maybe with large language models, we could get a large language rat model and hopefully start to have better understanding. There are people using large language models in AI to look at other like bird vocalizations, or I think there was whales. I think they were looking at whale vocalizations to start to get a better understanding of patterns and meanings. So yeah, maybe when I come over and visit, I'll be able to give you the rat dictionary
Sure.
in a couple of years.
That would be
And I
very
know we're just
interesting,
about at
sir.
time, so let me just close up with one of my favorite quotes here, and there's my email address as well if you want to ask any questions here. That friends, drinking lots of good water, avoiding alcohol, staying positive, and most importantly, lots of singing will keep you alive for a long time, said by, at the time, the oldest man in America, who was 115 years old. So keep using your voice, keep encouraging your patients to sing and vocalize. It was a real pleasure for me to be able to be with you today. And again, my email is down there. I'm happy to take any follow-up questions or communications if you have any more. So with that, thank you very much. I appreciate your time and attention.